Anuradha ma'am?
Shall I start?
Yeah, ma'am, please. Please go.
Good afternoon, one and all dignitaries and viewers on behalf of Women Pediatrician Forum in this webinar on anemia with different perspectives. Before starting actual session, let's observe 1 minute silence as a mark of homage to late Dr. Momita Deshpanath, who was brutally assaulted and murdered on duty at Ajekar Medical College, Kolkata, 3 days back only. This is very unfortunate and irreparable loss to medical fraternity as well as to family. Let's observe silence. Om Shanti. Thank you so much. As we all know, WPF always comes up with unique ideas to connect with the vibrant pediatricians all over the country and energetic youth of our country. In this sequence, a new idea of state-wise activity planning is being started from today onwards. With each month, one state of Indian Republic will come up with their self-planned innovative activity. The first state to start this concept is one and only one largest state in the country, our own vibrant Rajasthan. Myself belonging to Rajasthan, feel proud to announce that my state team has been enthusiastic to take this debut activity and has been trying hard to make this concept successful. We all know Anemia Mukt Bharat program was launched by Ministry of Health and Family Welfare, Government of India, to accelerate decline of anemia in 6 different age groups, and 2 of these age groups lie in pediatric, that is 6 to 59 months age group, and adolescent girls. According to NFHS 5 survey, 67% of children less than 5 years are anemic, and 59.1% of adolescent girls lie in this category. So it is a major health problem in pediatric age group. Much has been talked about nutritional and hematological aspects of anemia all over the country and pan world. Still, many non-nutritional and non-hematological conditions are underlying cause of anemia in many children. Very rarely we talk about these conditions. To elaborate and discuss these causes, we have planned today's webinar. Before this, I would invite our chairperson, Dr.Sangita Lodha ma'am, to seek her permission for today's session and words of wisdom from her. Dr.
Yes,
Sangita.
Dr. Anuradha. As from this month onward, we are going to include every month one state will just choose the topic and go ahead with their own ideas how to present, who will be the chairperson, who will be moderator and all, and the speakers also. And as you all know that this time our presidential action plan is IP ki baat community ke saath. About anemia we are going to talk, and Rajasthan has chosen the topic of anemia with different perspective. That is very good, mind-blowing idea, and I request all of you to just start the session.
Thank you very much for your permission, ma'am. To moderate today's session, we have our brilliant moderator, Dr. Anshita Arora, who is pediatric neurologist by her subspecialty, and she's been trained at famous BJ Wadia Hospital and Jaslok Hospital, Mumbai. And she is currently placed in GBH American Hospital and Medical College, Udaipur, as assistant professor. And I must say, she is my good friend of mine. She is doing wonderful job in her field. With this, I invite our moderator, Dr. Anshita Arora, to conduct further session. Dr. Anshita.
Thank you so much, ma'am. Thank you so much for the kind introduction. A very good afternoon and warm welcome to all the dignitaries here, all respected seniors and faculties, my mentors, and all the audience. Thank you so much for joining us today. Today, our discussion is focused on anemia, which is one of the most prevalent health condition of the children we know. And whenever we discuss about the anemia, even on the rounds, the multifactorial causation comes in the way. Nutritional factors, chronic diseases, and an n number of genetic conditions could be there. Understanding of anemia is important because it not only helps us in planning the treatment, but also helps in understanding the underlying disease of that. So today we'll be exploring the different aspects of the anemia with our panel of experts and who will help us in understanding by their valuable inputs. So to start the session, first I would like to welcome our guest of honor, Dr. Madhu Raturi, ma'am. Ma'am needs no introduction. Ma'am is a consultant pediatrician at Jaipur for last more than 4 decades. Ma'am is current IIP president in Jaipur branch, and she has been a backbone of the women wing always. She is a founding chairperson of IIP Women Wing, chief organizing for many of the women wing conferences. She has conducted a lot many health educative programs in the slum areas, and she has been featured as an entrepreneur and as a part of Startup of India's initiative for women entrepreneur development. We welcome you, ma'am, today in today's program. Going further,
Evening.
so
Yeah. Okay. You go ahead. Introduce all.
Going further, our chairpersons for today's session, Dr. Madhu Madhur ma'am. Ma'am has been associated with Mahatma Gandhi Medical College, Jaipur, and she has a vast experience, many publications in the various national and international journals. She has been a resource faculty in IIP workshops, and she has been an executive member of the IIP Jaipur branch twice, and for the IIP Jhalawar branch, ex-president. Ma'am has special interest in pulmonology, allergy, and immunology. We welcome you, ma'am, for today's session. Our next chairperson, Dr. Kusum ma'am. So ma'am has been an alumni of the SMS Medical College, Jaipur. She is a senior professor and head of the Department of Pediatric Medicine in SMS Medical College, and with a teaching experience of more than 35 years in the same hospital. Ma'am has many researches and many awards in her name. I myself have done SRship in the JK Lawn under ma'am's guidance. Then going forward, our next chairperson, Dr. Parmeshwari ma'am. Ma'am is senior consultant in pediatric medicine, Jain Mishra Hospital. Ma'am has worked in neonatology and ABO incompatibility and newborn, and will delivered many of the lectures in the universal immunization program, including the control and management of diarrheal diseases, communicable diseases and immunization, tuberculosis, and many camps for the mother and child at Jain Mishra Hospital. We welcome you, ma'am, for today's session. So after the introduction of all guests of honor and chairpersons, I would request Madhu Raturi ma'am to bless us for this session.
Good evening, dears. On behalf of my colorful state, Rajasthan, I welcome all my dear women pediatricians at this forum. And for this today's webinar of the month, and here we are taking a challenge. Anemia is still a challenge. Our speakers will do justice to that. They will talk about the different aspects. I'm so happy to see our Women Pediatrician Forum is growing gradually, and I wish all the success we should do. It is a platform for all of us to represent all the women pediatrician all across the country. And as we know, everybody has got a potential. So in this platform, everybody is welcome to speak. So today we are discussing anemia, and now over to Anshita for further proceedings.
Thank you so much, ma'am, the kind words. And now to begin the session without any delay. So for the first talk of today, I would like to invite Dr. Neha ma'am, Neha Agrawal ma'am. Ma'am is Associate Professor and heading the Department of Pediatric Nephrology in SMS Medical College, Jaipur. She is the instructor of ALS at BLS, Advanced in RP and Basic in RP. She is selected for IP and a GEMS program. And ma'am has been selected for a collaboration with the GOSH. She is also North Zone EB for Women Pediatric Forum and Divisional Coordinator for IIP UG Quiz. Welcome you, ma'am, and invite you for the first session of the day for the nephrology aspect of anemias. Over to Neha, ma'am.
Ma'am, kindly unmute yourself. Neha, ma'am, kindly unmute. Yeah, thank you.
Am I audible now? Okay.
Yes, ma'am.
Yes, ma'am, you are audible. You are audible.
Thank you so much, Anshita, and thank you WPF Rajasthan and WPF Central Committee for allowing us as a team Rajasthan to present this very important topic of anemia. And as you all know, we have already heard from our respected chair that anemia is very, very relevant and important topic being chosen by Central IAP also for their campaign. So what I would do in next 20 minutes is just talk about how we perceive anemia from the renal perspective. The major important thing is that it's just the tip of the iceberg we are watching right now. And is it really worth the pain that we look for anemia in a renal disease, whether it is acute or chronic? More so, what we perceive today is the acute aspect, and what is not seen is what is lying below the turf, actually. And that is what we need to look deeper. Having said that, it's just a figure and there are more to see and more to represent. The anemia is a major problem in all parts of the population, whether it is young or old or adolescent. More so, we focus more on the adolescent because they are the growing population and they would be the future of our own country and otherwise. So having said that, what we generally perceive with anemia is that the major part of anemia and its causation is because of iron deficiency or other hemoglobinopathies, and which is what is being stressed upon in the routine practice and routine care and policy making. But what is not heard and what is not focused upon is the other chronic diseases, which also form a major chunk of the people visiting the OPD, and workup is often missed in these patients. What happens with CKD? Now, CKD is a very common term which we often find in a renal disease when a child is not suffering, it's suffering from renal failure. Now, this would happen over a very prolonged period, and the anemia would progress from stage 1 to stage 5. And with each stage, the incidence of the anemia increases, very importantly because of the disease per se, which we would be seeing in the next few slides. So what is the causation? And also because of the various etiologies due to which the CKD has happened. So that is what is important here is that while we are working up these patients, we should focus both on the primary perspective and the follow-up and the complications of these patients. So why anemia should be corrected in a CKD? We are already doing our bit as a practitioner. We are providing therapy, we are providing supplements. So why the extra pain to be taken? It is very important because CKD being the vulnerable population, these patients are at risk for majority of the cardiovascular morbidity and mortality. More so, anemia would lead to a high cardiac output, stroke volume, heart rate, increasing peripheral vascular resistance as a part of the compensation, increase of the myocardial and the anginal episodes, even so in the children themselves, and with the increased incidence of blood transfusions, poor quality of life, and very importantly, a poor cognitive function and disturbed sleep patterns, and incidence of thrombocytopathy and vasculopathies increasing to a very high rate. So why anemia happens in CKD? As we understand that erythropoietin is the major important part of the whole story here, but I would focus on the other etiologies also. The major important factor here is the decreased erythropoiesis. Now, decreased erythropoiesis can happen because of primary reduction in the erythropoietin or its resistance, more so happening because of multiple reasons like inflammatory cytokine predominance, absolute iron deficiency, can be because of dietary factors or other reasons, increased losses. There is also a concept called as functional iron deficiency, which is primarily because of the activation of the reticuloendothelial system, leading to iron blockade, and it's a kind of functional deficiency. More so, the uremic toxins in these patients, the use of drugs like AC inhibitors can lead to angiotensin receptor 2 blockade. Hyperparathyroidism, which you very commonly see in these patients, leads to myelofibrosis and poor response. Infiltration, shortened RBC survival because of the toxins themselves, hemolysis happening because of the activation of the reticuloendothelial system, and very importantly, which we often miss, is the lot of sampling and the phlebotomy which we are doing in these patients, and the GI causes, which is very predominantly because of excessive use of drugs, multiple uses, and constipation, which is often neglected in these patients. So this is the whole cycle of what happens and where happens. So as we all understand that uremic toxins, inflammation, EPO resistance, and ultimately leading to poor survival and increased destruction, and finally the end result of anemia. So I'll just brush up with a small incidence or a small case, which we often witness in our routine practice. Generally, we come across patients who are in their adolescent age group and they come to the OPD with a history of multiple OPD visits just for the simple reason that the child is having weakness, fatigue, and an increasing pale look or a yellowish discoloration. The child is always subjected to CBC and LFT, and I am very sure that many would resonate with what I'm showing here, and they continue to receive transfusions without any reason. Very commonly happens when these children are referred to us, none of them have been subjected to a renal function test. And the child doesn't show improvement. Definitely, the child would never show improvement because what we have been doing is just symptomatic management. We never went down the iceberg. We never went down the surface of what was happening deeper. And these children begin to worsen. Now, what is happening here is that we never investigated the child in detail. So did we need to look deeper here? Yes. Other than the very important things which we have done, like CBC or a PBF or a RBC indices, a retic count, kind of, reticulocyte hemoglobin ratio, DCT, a simple LFT, but also detailed RFT evaluation in the form, as I say, albumin, cholesterol, and total protein are also RFT for us. So always focus on these things. And when you come to the etiology, we need to focus on two very important pathways. One is diagnosing the primary disease, because unless you target that, you cannot correct anemia. And also targeting what is the degree of compromise with respect to anemia and its etiology. So we should always do a detailed iron study that includes a serum iron, TIBC, ferritin, derive the TSAT value, the levels of B12, folate, and stool occult blood, very importantly in our setup, a urine routine to see whether there is active hematuria or any losses there. Always rule out infections because these are the vulnerable population, and the infections lead to more of cytokine, in storm and more inflammatory mediators, making the anemia poor to respond. Always do a thyroid status in them. And then coming to the etiology, you should always do ANA and dsDNA and a DCT in them. Here, I focus upon this point here because many adolescent girls, they come to us with a simple complaint of pallor and anemia, and they are never looked upon with a suspicion of SLE and often missed. And when these patients drop back to us in the later follow-up, they're already into an advanced stage of SLE nephritis. So very importantly, and very sorry to say that this is the point where we lack, that we don't keep a wider angle of vision here, and we should always try to focus on this important point. Importantly enough, as I said, that hyperparathyroidism is one of the reasons which leads to poor response in CKD. We should always try to do the whole calcium profile, which includes vitamin D, calcium, phosphorus, alkaline phosphatase. I forgot to mention PTH here, and which should also be done. Needless to say, all these tests, they come with a pinch of, salt. I should say you should take the investigations with a pinch of salt, because many confounders are there which would alter the value of results. As I said, CKD are prone to infections. So ferritin being an acute phase reactant, you should always not very much rely upon the value of ferritin as an acute phase, because it's an acute phase reactant. And you should not really give a lot of importance to a higher ferritin value and say, okay, this child doesn't need anything. Rather than doing that, you should always focus on the other mediators, other parameters like TSAT and the value of serum iron, etc. Similarly, a viral screen should always be done, because parvo being a very important, viral illness, which leads to very high incidence of PRCA, that is the red cell aplasia happens in these patients in a later stage. And importantly enough, USG-KUB should be done in all patients of CKD. So just to highlight a very important thing here is that the whole phase of erythropoiesis is in two parts. So the one part where we have the erythropoietin dependent phase, and the other is the iron dependent. So unless you are doing a proper iron supplementation in your CKD patients, you will never be able to achieve, you will never be having a good hemoglobin unless you're targeting both the parts of the whole cycle. So while investigating these patients, we keep a very, very less therapeutic window. When the hemoglobin is less than 11 in our patients of CKD, we begin to investigate them. And if they are not responding to treatment, the example being that they are either dialysis dependent or non-dialysis dependent. Especially so when they're doing a dialysis, they are more at risk of anemia. And this stresses upon the fact that they should be worked upon about the anemia in a detailed manner. So the whole flow chart here tells you the simple things which you have been doing already. But what I want to stress upon here is that don't just leave the things there. You need to follow them up. You need to redo their hemoglobin every 2 to 4 weeks to see whether they are responding to what you are doing. So as I already said, the iron status in the CKD patients is not totally reliable on the serum ferritin, but you should always focus on a good value of TSAT ranging between 20 to 40%. And some of the theoretical markers are serum transferrin receptor and CHR, which I will not really rely on much. So this table is too crowded, but the only message here is that all the things should be taken with a pinch of salt. There are a lot of confounders to change your values and try to see on a wider picture rather than focusing on a one value. The treatment is very simple. Having said that, it's not so simple. Just replacing iron is not enough. You have to titrate your dose with every cycle. The ESAs, that erythropoietin stimulating agents, the new kids on the block are the HIF PHIs, that is the hypoxia-induced factor prolyl hydroxylase inhibitors. The transfusions, definitely in CKD, I should say, stay away from transfusions, avoid them as far as possible, because in future, these are all transplant candidates. So we don't want to sensitize our patients. And of course, the nutrition, which is the most given least importance, should be given more importance here. So these are some of the iron formulations which we use. A lot of companies, I have a disclaimer, I don't advocate for any particular brand, but I would just say use whatever you're using in the adequate doses and adequate manner, and guide your patient through how she should take the iron formulations. Similarly, what is the target for the therapy? We always want the TSAT to be above 20%. Until that, we supplement the iron in adequate doses, beginning with 3 milligrams and then going up to 6 milligrams if needed. And iron deficiency patients should continue with iron and folic acid at the same cycle, along with ESAs. Now, what ESAs do is they reduce your journey to achieving a good hemoglobin. That is what they do, but never start ESAs unless your TSAT is more than 20%. So this is just a cycle to explain. In some of the dialysis-dependent patients, IV iron therapy is recommended now, and it should be used with caution always, looking at a lot of incidences of anaphylaxis, but it's safer to use in dialysis-dependent patients and helps to achieve the hemoglobin level at a very early manner. Sometimes the ESAs don't respond. So when we start ESA, we start with a lower dose. There are a lot of formulations available in market, but having said that, the other formulations are costly. So whatever is available with you, start with a lower dose of 80 to 120 units per kg per week, and then go on to increase it, measuring your hemoglobin every 2 to 4 weeks. If you don't achieve a normal hemoglobin that is more than 11 or around 11, when you're using the maximum dose of ESA of 500 units, that is too high a dose. If you're not able to do that, always suspect why the patient has not responded. So there is always a reason. The most important reason is that you have not given your patient adequate dose of iron, or there is ongoing inflammation, infection, hyperparathyroidism, or there are other reasons like, as I said, parvo infection. So you should always focus on the other areas of compromise which can happen in these patients. The point where I mentioned there are various formulations, there are now good formulations available which need less dosing, smaller amounts, and less frequent intervals, making it very important that the patient is compliant with your treatment. So you can always go for these better formulations like darbepoetin as compared to erythropoietin in these patients. Very importantly, you should always focus on other things also, like use of drugs. So drugs like ACE inhibitors and ongoing malignancy or other diseases should always be focused upon. For example, you can always have a coexisting hemoglobinopathy in a patient of CKD. So try to rule out all the parameters, all the confounders before saying that patient is not responding to treatment. And why should we use ESA in the early course of treatment once your patient is already into CKD stage 3, 4, and 5? Is because the outcome is better, the transfusion is not required, you have less transfusion-related complications, and the quality of life is better. So ultimately, our aim is to reduce the cardiovascular morbidity in an early manner. But there are ESAs which have side effects. So ESAs can worsen your hypertension, keep a watch over that. Sometimes the patient may experience seizures, graft clotting, strokes, and poor dialysis clearance. So you should always look for these reasons and try to remove them. As I said, there are nucleids on the block which use the hepcidin pathway. Having said that, these drugs are not easily available, and there are very few studies for children. As of now, the most important agent which is in vogue right now is roxadustat, and it is considered to reduce the need of ESAs and complications, and is considered a very good drug where resistant anemia is considered. So these are few of the landmark trials which are happening in anemia and kidney disease. And how much is more? So in the end, I would just want to say, don't overdo what you are doing. Don't target a hemoglobin more than 11 or 11.5, because with each gram of hemoglobin which is rising, you are always at risk for a lot of thrombotic complications and strokes in these patients. So we should always try to titrate a treatment and follow these patients up very frequently. A small note on patients other than CKD, for example, other causes of renal anemia like HUS or SLE, I would say that a very high index of suspicion is required. For example, a child coming to you with severe anemia, thrombocytopenia, and renal failure, please suspect HUS in these patients. But these diseases being very rare, I have not included a lot of slides in my presentation. But needless to say, in OPD, you have to keep a very high index of suspicion, because we cannot afford to uselessly treat our patients and lead them the poor way. We need to help them in every way possible and keep our windows and antenna open for keeping a high index of suspicion for renal diseases as the cause of anemia. Thank you so much.
Should I?
Yes, Anshita, to you back to you.
Yeah. Good evening, good afternoon, everyone. Am I audible?
Yes, ma'am.
Okay. Good afternoon, good evening, everyone. First of all, I would like to thank Dr. Anshita for a very nice introduction, kind words of introduction you have given. And thank you, Dr. Neha, for your excellent talk. And you have covered all the aspects of anemia and renal disorders in a very short time and very beautifully.
Thank you, ma'am.
As Dr. Anuradha said, and now we all know that the major cause of anemia is the nutritional cause, and for which you already said in your talk also, and Anuradha said, that we supplement the iron, folic acids, and B12. But sometimes patient does not respond to their hematinics. This is the time we should think for other causes for which we are together today, and we are discussing the other problems like kidney problems or GI problems or endocrine problems. And so this is very important to think of other causes also. As Dr. Anuradha said, the Ministry of Health and Family Welfare, Government of India, has started intensified National Iron Plus initiative, which has ambitious and detailed recommendations for iron folic acid supplementations throughout the childhood. She has very well said, not only throughout the childhood, but till 45 years in the women, till 45 years of age, we should supplement the iron. As Dr. Neha said in her talk, the renal disorders and the anemia, because of the renal disorder, the main cause is the CKD. We all know that. And you have explained very well about the pathophysiology, about the symptomatology, diagnosis, and what is the management, and till now, what are the recent medicines available for managing the anemia. The crux of the today's talk, what I understood from your talk, is the erythropoietin erythropoietin stimulating agents along with iron therapy is the iron supplementations constitutes the treatment of choice for anemia of CKD.
Yes.
And you said a word about HIF, PHI, that is hypoxia-inducible factors and prolyl hydroxylase inhibitors. They are the newer drugs or oral medications. And what I have come to know that this one of the drug, that is Dopradustat, is recently approved by the FDA, is on 1st February 2023 only. But this is approved for the adult patients who are on dialysis. The patients who are not on dialysis, this is not given. But I hope in the future for our young children, this oral medications, if available, they will be free of pain of injections, what they get because of the erythropoietin injections and all. So hope for the good things. And thank you so much, Dr. Neha. And congratulate you very good presentations.
Thank you,
And
ma'am.
over to Anshita for further proceedings. Thank you.
Dr.
Hello.
Anshita?
Yeah, yes, ma'am. Yeah. Am I audible, ma'am?
Yes,
Am
ma'am.
I
Yes, ma'am.
audible?
You are audible. Yes,
Okay.
ma'am. You are
Okay.
audible.
Okay. Thank you, Neha ma'am and Kusum ma'am, for the excellent talk and the review of the talk by Kusum ma'am. Thank you so much. Moving forward for the second talk of the day, that is the endocrine aspect of the anemia. I would like to invite our second speaker, Dr. Pragya Chitlangia Sumani ma'am, an alumni of SN Medical College, Jodhpur. Dr. Pragya has been trained in sonography from Suryanagri USD and Doppler training. And she has done a fellowship on pediatric endocrinology from MedEd Classes Regency, CDER Kanpur. She is consultant pediatrician and owner at Mahesh Hospital, Bhilwara, conducted multiple workshops and conferences and authored and co-authored various of the books. So I invite Dr. Pragya for the next session, the endocrine aspects and anemia. Welcome, ma'am.
Hello, everyone. It was nice to hear to Neha, and she gave a very elaborate talk on the renal aspect, and I'll be continuing with the endocrine aspects. So, many of endocrine disorders are associated with anemia, but usually this anemia is not very severe or the presenting feature of the disease. It is just associated feature. But it may be found in many endocrine disorders like thyroid, pituitary, adrenal disorders, then parathyroid glands, gonadal disorders, right? And usually it is mild to moderate. And along with that, in many disorders, the plasma volume is reduced. So usually this anemia is very much masked. And when we start the treatment of disease and plasma volume returns to normal, this will get unmasked. And usually the cause is multifactorial for the anemia in most of the endocrine disorders. Now, first and foremost, we'll be coming to thyroid. Uh, Thyroid disorders are very frequently associated with anemia, but usually it is underestimated as the plasma volume is also reduced and body's requirement of oxygen is also reduced. So usually, like a hypothyroid patient will already be sluggish, and also we won't be able to judge that this weakness is due to anemia or fatigue is due to anemia or due to thyroid disorders. Then causative relation is mostly ambiguous, and the most common type that we will find is normocytic, though we will find microcytic and macrocytic also, but the anemia that is only due to thyroid disorders is mostly normocytic. What are the causes in a thyroid patient? So, first and foremost, bone marrow depression. The thyroid hormone itself, T3 itself, stimulates the colony forming units, erythrocytes, and it helps in erythropoiesis. Then, secondly, decreased erythropoietin production, comorbid diseases, then concomitant deficiencies like those of vitamin B12, iron, or folate deficiencies. These may also result in anemia. Then altered iron metabolism and decreased iron absorption, mainly due to achlorhydria. Achlorhydria is mostly seen in thyroid deficiency itself, and it may be seen in pernicious anemia, which is associated with autoimmune thyroid diseases also. Then oxidative stress, this is more important in hyperthyroid patients, which would result in anemia. Autoimmune conditions like pernicious anemia, atrophic gastritis, autoimmune hemolytic syndromes, rheumatic disorders, all these would lead to anemia. And then in hypothyroid patients, there is a predisposition to menorrhagia. So this would lead to blood loss and hence in iron deficiency anemia. Then I will categorize into microcytic, normocytic, and macrocytic anemia. So when microcytic hypochromic anemia is found, it is always due to iron deficiency. Iron deficiency in myxedema can be due to menorrhagia, as I already discussed. Patients of hypothyroidism are predisposed to menorrhagia, and many a times in girls with menorrhagia, we have to do a thyroid profile so that we can diagnose the condition. Then achlorhydria and possibly impaired iron absorption due to thyroid hormone deficiency. So thyroid hormone is also important for absorption of iron. And in thyroid hormone deficiency, iron absorption will be impaired, so leading to iron deficiency anemia. And the serum iron levels in these patients will be subnormal. So this is how we will diagnose iron deficiency anemia. So hemoglobin will be low in all, but if we do serum iron levels, they will be low in these patients. And this anemia usually responds to iron therapy, and this won't respond to thyroid replacement alone. Then we come to macrocytic anemia. So macrocytic anemia in hypothyroidism, it can be due to multiple reasons. Firstly, malabsorption of B12 and folate. So as it is during thyroid deficiency, the absorption of B12 and folate can be impaired. Then pernicious anemia, which is an important cause. It is an important association of autoimmune diseases. So in patients with autoimmune thyroid disease, a pernicious anemia can be accompanied, and it can result in macrocytic anemia. And then insufficient thyroid hormones, even without a nutritional deficit, can lead to macrocytosis in 55% of patients. So in these patients, neither B12 will be low, nor folic acid will be low, and even pernicious anemia will not be there, but even just insufficient thyroid hormones will result in a macrocytic anemia. So proper evaluation is crucial, and thus we can reach to the underlying cause. Then in a significant proportion of the hypothyroid patient, they have anemia that is direct manifestation of hormone deficiency. And this is known as uncomplicated uncomplicated anemia of hypothyroidism. In children with hypothyroidism and anemia, this is the most common form. And often their height will be below the 3rd percentile. In PBF, we will find acanthocytosis, which is abnormal red blood cell with spiky projections. And in about 90% of cases, this will be there. And this responds to thyroid replacement alone. Even if we don't give iron, just with thyroid replacement, they would mostly respond. Normocytic anemia is primarily due to deficit of thyroid hormones rather than a nutritional deficiency. So what does a thyroid hormone deficiency do? It reduces the stimulation of erythroid colony development. Then it decreases oxygen distribution to tissues. And thus the signals for erythropoietin production are reduced and low erythropoietin levels are there. So the thyroid hormone deficiency, the entire body goes sluggish, even the erythropoietin production will be reduced, and the bone marrow production of the cells will also be reduced. And then when we replace, everything will be activated and blood formation will be increased. Normocytic anemia, which is characterized by reticulocytopenia, hypoplasia of erythroid lineage, decreased erythropoietin levels, and a generally regular erythrocyte survival. So erythrocyte का जो survival span है, that won't be reduced, only the production will be reduced. Then we come to hyperthyroidism. This was about hypothyroidism. So majorly 3 forms: microcytic, macrocytic, and a normocytic, which responds to just thyroid replacement. Then in hyperthyroidism is associated with mild unexplained anemia in 10 to 25% of patients. And the patients with more severe or prolonged cases show greater anemia. So the duration of disease also affects the severity of anemia. Pathogenesis is not clearly understood, but an increased plasma volume and ineffective erythropoiesis. So in increased plasma volume, the hemoglobin concentration will be normal, but due to the expansion of plasma volume, it will show up to us as anemia. But an ineffective erythropoiesis may also play a role. And in autoimmune conditions, autoimmune thyroid diseases, hemolytic anemia and pancytopenia, which is responsive to hyperthyroidism, has also been reported. So this was about thyroid. Next, we come to adrenal disorders. So primary adrenal insufficiency, a decreased red cell mass with concomitant decrease in plasma volume is seen in Addison's disease. Though not very severe, never it will be a severe anemia, just mild anemia in some cases. And then when we start the treatment, the plasma volume will expand and the hematocrit will dip in these patients. So even after the starting the treatment in Addison's disease, we have to monitor them for hemoglobin concentrations and supplement accordingly. Pathophysiologic basis of this is not very clear and is ambiguous. Then again with adrenal disorders, just as with autoimmune thyroid disorders, pernicious anemia can occur. And with APS1, that is polyglandular autoimmune syndrome, it is associated with mucocutaneous candidiasis and hypoparathyroidism. So a patient having mucocutaneous candidiasis, hypoparathyroidism, and anemia, we should look for Addison's disease also. So you have to have a strong suspicion to diagnose these conditions. Then now we switch to the gonadal hormones, importance of gonadal hormones in in the anemia. So after puberty, we all know blood hemoglobin concentration and red cell count are higher in men than in women, up to about 10 to 13%. And in enucoid or castrated men, these values decrease to within normal female range. Normal men have higher urinary erythropoietin levels than women. It is about 3 times higher. And primary cause of this difference is stimulating effect of androgens on erythropoiesis. And also some studies indicate that estrogens may have a suppressive effect on the erythropoiesis. So their action appears to be complex. Mainly, probably there is evidence that they stimulate the erythropoietin secretion, and this is a direct effect on marrow-erythroid progenitors. Decreased androgen production due to orchidectomy or medical androgen blockade can cause anemia. So, if any child has undergone orchidectomy, we have to monitor his hemoglobin levels. Then with pituitary disorders. Then pituitary disorders in MPHD, multiple pituitary hormone deficiency. Again, we have moderately severe non-progressive anemia. And this is usually, again, normocytic normochromic with very normal looking red cells. Although slight hypochromia and macrocytosis, but this can be due to associated deficiencies also. Primarily, this anemia is also due to deficiency of thyroid, adrenal, and androgen hormones. So, and they usually respond to growth hormone and other hormone replacements. Then panhypopituitarism likely affects erythropoiesis by reducing tissue oxygen consumption, similar to in thyroid diseases. So this similar to hypothyroidism, this is leading to a decreased erythropoietin secretion and a reduction in red cell mass. A combination of thyroxine, cortisone, and growth hormone is very effective in treating this kind of anemia. And lastly, we come to hyperparathyroidism. I think Neha has already covered a part of it. So it is anemia is a rare complication of hyperparathyroidism. Anemia is again normocytic, normochromic, and they typically occurs in very severely hyperparathyroid patients. And how it is indicated? It is indicated by bone cysts, subperiosteal bone resorptions, and high levels of serum calcium, alkaline phosphatase, and PTH. And this anemia is corrected in most of the patients just by removal of abnormal parathyroid glands or parathyroidectomy. And myelofibrosis is also commonly observed in bone marrow biopsies in these patients. Thank you.
Thank you so much. Hello.
Yes, you are audible.
Yes,
Thank you so
please
much,
go ahead.
Dr. Pragya, for the wonderful enlightening session. And now I'll request Dr. Madhu Mathur ma'am for her expertise regarding the topic.
First of all, I would like to thank the organizers to giving me the chance to chair this very nice session. And thanks to Anshita for giving such a kind introduction. And it was, I would like to congratulate Dr. Pragya for elaborating so nicely such a complex nature of anemia with endocrinal disorders. Just to sum up, she has done a very nice job. But anemia due to endocrine disease is usually, as she told, mild to moderate. But the severity may be masked due to decreased plasma volume, and the decreased RBC mass is masked due to this. And this should be kept in mind. Then this anemia with endocrinal disorders is can be, as she has told, it can be, it's really difficult. It can be microcytic, it can be macrocytic, it can be normocytic. And there are, because the pathophysiology of endocrinal disorders is multifactorial, along with there may be deficiencies of iron, vitamin B12 and folate. So the deficiencies we all know, it may be due to anemia, it may be due to decreased erythropoiesis and various disorders, decreased erythropoiesis, decreased iron absorption due to achlorhydria, she has very well explained, or impaired utilization, or it may be the pernicious anemia and autoimmune condition of these different endocrinal disorders, and hemorrhage we cannot understand. So all aspects of anemia, whether it is a formation, it is its absorption, its utilization, or it is loss, everything can be along with the deficiencies of the iron, this vitamin B12, and so it's very difficult to judge these conditions, because in hypothyroidism, in adrenal deficiencies, in hypopituitarism, all these factors come. Like in hyperthyroidism, there may be increased erythropoiesis, but there also sometimes there's increased destruction of RBCs, which can lead to anemia. So it's a very complex situation. Hyperparathyroidism, both have explained very well. I will not go further in detail. One thing which is not touched is type 1 diabetes, where also there is autoimmune gastritis occurs, which can lead to pernicious anemia. Along with that, of course, if extending chronic renal failure, along with deficiency of iron and B12 and folate can lead to anemia. So any autoimmunities here also works along with this, as occurs in autoimmune thyroiditis or autoimmune adrenal insufficiency. Likewise, here there's also autoimmunity works in type 1 diabetes, which is also a factor to lead to some anemia. And I think Dr. Pragya will agree with me. So there is a comprehensive approach is needed to address the anemia with endocrinal disorders. During diagnosis also, we have to, besides the routine CBC, iron studies, vitamin studies, we have to look for whether it's a renal disorder. We have to look for endocrinal workup. If it is, they are not responding to the usual treatment, we have to look further, or there is some malabsorption syndrome or what. So it's really a complex situation. And while treating, along with the supplementation, it will not be a complete recovery if underlying endocrinal disorders are not managed properly. And sometimes here also, as erythropoietin stimulating agents are needed at certain situations, or as she has gonadal androgen problems, also she has already highlighted that if in androgen deficiencies or leads to there's or in the estrogen therapy also can lead to anemia, and they all have to be addressed properly as and when needed. Thank you very much.
Thank you, Pragya ma'am and Madhu ma'am, for a wonderful session of this. Endocrine disorders per se are very complicated and tricky, and to make them understand so simply in a crisp manner is definitely a big task. Thank you so much, ma'am. So for the next session, I would like to invite our third speaker of the day in the same chain, Dr. Anubhuti Bhardwaj. Dr. Anubhuti has done her fellowship in pediatric gastrohepatology and liver transplant, and currently she is working as a consultant pediatric gastroenterology and hepatology at Hope Hospital, Jaipur. Her area of interest are inflammatory bowel disease and functional GI disorders. She has been awarded a lot many awards, including Rajasthan Gaurav Award, Brahma Ratna Award, and IIP Daughters Day Award, and she has many publications and papers. So in the series going to the gastrointestinal causes of anemia, I would like to invite Dr. Anubhuti for the session.
Thank you so much for inviting me.
Ms. Pallavi, can share your slides, Dr. Anubhuti, if you are finding any problem.
Ma'am, we can see your desktop. Just start your presentation. Ma'am, are you there?
Yes, I am able to hear.
Yeah, you can just click on your presentation and start the presentation, or else I'll do that.
I think, Pallavi, you can start the session. If suppose
No
Dr.
problem,
Anubhuti is getting any
There is
problem.
some network issue. Just give me a minute.
Okay, no problem.
Is my screen visible?
Yes, we can
Yes.
see. Done.
Hope it's
Yes,
visible.
ma'am. Yeah, it is visible.
But is it a slideshow mode? I think you have to come to the slideshow mode, Dr. Anubhuti.
Yeah, it's there on
1 minute.
Yeah, okay.
Is it visible now?
Yes.
Yes, ma'am, it is visible.
So, good evening all. And at the outset, I would like to thank Women's Pediatric Forum for giving me this opportunity. So, directly straightforward, I'm coming to my topic, that is anemias with different perspectives, and I'm taking the pediatric.
Just a small interruption. Can you just put it in a slideshow mode?
Ma'am, it's on the slideshow mode only.
No, Dr. Anubhuti, we can see a small block also, know me better. That should not come on the screen.
Okay, okay, ma'am, just give it.
So you have to go to the slideshow mode.
Actually, that was on the presenter's mode. Hope it's fine now.
Now it is okay. Now it's
Okay.
perfect. Yeah. Thank you. Now you can go ahead.
Yeah. So starting, I'll just give a brief that anemia is a diagnostic challenge during childhood, and it is very common in preschool children with a worldwide prevalence of 9.6%. And GI diseases are very well known for the causes of refractory anemia in children. So basically, it is because the iron deficiency, and what causes iron deficiency as the age progresses, its requirement increases, and low bioavailability of the dietary iron. As well as in some infants which are cow milk fed or with having a cow milk protein LD, there is intestinal blood loss, which eventually leads into the different set of anemias. So the most common is the malabsorptive state, that is predominated by celiac disease by 84%. Then comes the cow milk intolerance, Crohn's disease, and giardiasis. Less common is chronic non-specific diarrhea, that stands for 11%. So I'm just taking an overview of common pediatric GI disorders and their links to the anemia. Like it's in the Crohn's disease. So basically it is a type of inflammatory bowel disease which is characterized by inflammation, which leads to the damage to the GI tract. Now, how it causes anemia is because of the chronic inflammation. Because of the chronic inflammation, the intestine is not able to absorb the important nutrients which are required for the body's growth and well-being. Again, same factor involves in the malabsorption, and certainly as Crohn's disease has a characteristic feature for the blood loss. Ulcerative colitis, yet another type of IBD, primarily affecting the colon and the rectum with a continuous involvement. It causes inflammation of the mucosal layer, basically the superficial layer, leading to the diarrhea, abdominal pain, and the rectal bleeding. It is related because of the chronic blood loss, because of the inflammation, the superficial ulcers bleed and may lead up to the anemia. And again, inflammation, as we have discussed with the Crohn's disease. Celiac disease, the most leading one. It is an autoimmune disorder, and because of the ingestion of the gluten, it may lead to the damage to the small intestine. And the affected villi is responsible for the nutrient absorption. So because of that damage to the small intestine and the villi, there's no absorption of the nutrients like vitamin B12, iron, fats, soluble globules, and everything like that. So basically it will have malabsorption and eventually lead to iron deficiency anemia. Some of the gastrointestinal bleeding, such as in peptic ulcers, polyps, or vascular malformation, which may also lead to acute and chronic blood loss. Inflammatory conditions such as eosinophilic esophagitis, though rare, but yeah, may present with this, or colitis can also attribute to anemia. The causes and the link to the anemia is definitely with the inflammation. So I'll lead this discussion based on the cases. So here is my first case of a 10-month male child who came for a regular vaccination visit and seems well nourished, but pallor was
Dr. Anubhuti, unmute yourself. You have been muted. Unmute yourself first.
Is it fine?
Yes.
So on examination, we found that pallor was present and the liver was 2 centimeters, though spleen was not palpable, and rest of the systemic examination was absolutely normal. So further investigating, we found hemoglobin to be quite low, that is 6.4 grams per cent. MCV and RDW was deranged. Retic count was 3%. So we took a PBF detail and impression was iron deficiency anemia. But we were worried for the cause. So we did a retrospective interrogation with the mother and found that iron formulation was there since last 3 months. Dietary history, that the child was having only few breastfeeds and the fresh cow milk. Approximately half of the feeds were cow milk. And there was an infrequent weaning. So, and the child was also taking an inadequate dose of ferrous iron. And on inquiry, the mother has just finished 1 bottle of medicine. So that was surprising. So why I'm stressing on the history that the child was having only few breastfeeds and rest of the feeds were fresh cow milk, because excess of cow milk intake, especially due to the bottle feeding, can lead to iron deficiencies, replacing and weaning of the food, and poor source of iron as well. So nutritional iron deficiency anemia was there. We put on the adequate dose of iron for an adequate time. We did retic count on day 5th of oral iron, and that's supposed to be increased from 3 to 6%. Adequate weaning of food was advised, and CBC was done later on at 3 months. Hemoglobin from 6 turned out to be 12.5%. All other indices returned to normal, and we continued iron for the required time. So what's the learning here? That the dose should be appropriate, that is 3 to 6 mg per kg per day of the elemental iron. We have n number of preparations for oral. Ferrous sulfate, alternate forms, we had ferrous fumarate, gluconates. So check for any concomitant medications or the dietary elements. Rule out the side effects. From gastro point of view, there is nausea, vomiting, constipation, and diarrhea. Continue iron for 3 months for replenishing the stores. So use small divided doses once a day or even alternate days. It's always better than not giving, because often we have seen that child who is vomiting or having constipation or diarrhea, we avoid iron. So instead of avoiding that, we can give in small doses, or we can increase the frequencies, decrease the frequencies. So what are the causes of inadequate response? That is the some or the other ongoing blood losses. High gastric pH, that is there in peptic ulcer diseases or some form of the other GERDs. Inadequate absorption, that is in diarrhea or malabsorption syndromes. Chronic inflammation or incorrect diagnosis. Heading towards my second case of 1-year female, which came with the complaint of loose motions that were multiple episodes, 6 to 7 per day, sufficiently large amount and a good quantity, associated with blood, passing worms in stool 1 to 2 months. On examination, we find that weight and the height was less than 3rd percentile. Pallor was present and perianal excoriation was there. We took a feeding history and found that breastfeeding was only there for a few days and then started on cow milk with 1:1 dilution since 25th day of life. That means the child had a negligible amount of breastfeed. Evaluated outside and we found that anemia and thrombocytosis was there. CRP did n number of times, which was normal. Stool routine was done and it was 10 to 11 high power field with no ova and the cyst. Received multiple dewormings and antibiotic courses. What next? We have anemia and thrombocytosis along with the perianal excoriation, as discussed, and stool routine showed 10 high power fields pus cells. So basically we had issue with colitis, anemia, failure to thrive, and because of early weaning with the bovine milk. What to do now? So we did the endoscopies, and on sigmoidoscopy we had this picture. We found some of the nodules, and on a rectal mucosal biopsy we found that the child is having cow milk protein allergy. So we stopped milk and the milk products. Eventually, diarrhea and blood in stool resolved on extensively hydrolyzed formula. We checked his weight on our follow-up of day 15. Weight gain was present and hemoglobin shoot up. In literature, we reported that Harmons et al. Reported that the prevalence of anemia in cow milk intolerance as 10%, which is quite a good amount. So my next case is of a female child of 6.5 years, came with a diarrhea since 4 years. Pain abdomen and abdominal distension was present, irritability was there, and failure to thrive. You can see this cute little girl. And on examination, we found that weight was less than 3rd centile, height also less than 3rd centile, pallor was there, clubbing, rickets, pedal edema, everything was there. There was a gross abdominal distension and liver found to be 2 centimeters. On investigating the child, we found that hemoglobin was just 4.1. Albumin was on the lower side, that is 2.8, and rickets was evident. We did Monto's, which was negative, and USG showed multiple fluid distended small bowel loops. So we evaluated the child on the lines of malabsorption. We did TTG IgA, which was positive, as well as EMA, endomysial antibodies, was also positive. So the clinical impression we found from this was malabsorption. So we did an upper GI endoscopy and find that there was scalloping of the duodenal folds. Blunting was there, seen in the mosaic pattern. Biopsy was sent and found that it was MASH 3C as the diagnostic criteria for the celiac disease. Villus atrophy was present, crypt hyperplasia was evident. So diagnosis was confirmed that it is a celiac disease. On follow-up after 10 months of a treatment, that is, we kept the child on a gluten-free diet, and weight put on was there, 8 kgs in 10 months, and height also 20 centimeters. There was no other symptoms as the presenting complaint was there, everything resolved. So we approved the diagnosis, histologically, serologically, and clinical response, the child improved well. So the learning here is, as I have written in a slogan, that eyes can see only what the mind knows. So before evaluating a child, we if we have anemia, we should think GI disorders, malabsorption for the first, and in the that case, celiac disease should be our priority. We always need to rule out celiac disease. So common typical symptoms include short stature, anemia, refractory type, rickets, recurrent abdominal pain, constipation, hepatic stenosis. Do not overdo or underdo the diagnosis. Seek the help of an expert in case of any confusion. So next case is of a 5-year female with chronic abdominal pain since 2 years. There was significant abdominal distension and vomiting was present. Loose stools on and off. On examination, we found that height and the weight centile were less than 3rd. Anemia was there and rickets was evident. So we found it to be organic cause, and we evaluated the child with the blood investigations, and hemoglobin turns out to be 6.1. TTG IgA was more than 100. Rest everything was normal. So we did endoscopy. We find that there was a marked duodenal scalloping and suggestive of malabsorption. Biopsy came, several villus atrophy was there associated with crypt hyperplasia. So diagnosis was celiac disease. So here the learning is that the iron deficiency anemia refractory to iron therapy can be the sole manifestation of celiac disease, and prevalence of celiac disease in refractory iron deficiency anemia can be up to 20%. So always rule out iron deficiency anemias along with this celiac disease. Hermans et al. Reported that the children with celiac disease were iron deficit, defined as a presence of microcytosis and serum iron concentration less than 40. Basically, refractory microcytic anemia appears because of the compliance, proper salt of iron, adequate doses, dietary factors, excesses cow milk, and pica, etc. Celiac disease should be ruled out, chronic infections and chronic inflammatory disorders. So another case of a 13-year female child came with chronic pain abdomen since 2 years, chronic diarrhea was there, and failure to thrive in since 3 years. We evaluated and we found that there was a history of surgery and diagnosis was Scott's abdomen. Received ATT for 3 courses. On examination, we find that weight was 25 kg, which was less than 3rd centile, and there was a short stature, anemia, but no lymphadenopathy. So colonoscopy, we did the colonoscopy as there was a chronic diarrhea and we are not able to find the cause for that. So we found there were deep ulcer and cobblestone stricture, cobblestoming and strictures found to be fistulas. Histopathologically suggested of Crohn's disease, cryptoabscesses, non-caseating granulomas, and transluminal inflammation. So we treated on the guidelines, according to the guidelines, and with the steroid mesalamine and later on the azathioprines. We got the response. Also, in a literature review, it was evident that the Crohn's disease, anemia has been reported in 60 to 80% of the patient, and iron deficiency is there in 40%. So here learning is that anemia, which is the most common extraintestinal manifestation and complication of inflammatory bowel disease. Idiopathogenesis is complex and multifactorial. Main factors which are included are blood losses from the intestinal bleeding, acute or chronic, due to some of the other ulcers, poor absorption of vitamins and minerals through the inflamed intestinal mucosa. Early diagnosis and appropriate treatment is far more important. Another case, 18 months female presented with loose stool since 6 months of age, 5 to 6 episodes per day, small with fresh blood immediately after the stool. There was severe anemia. The child received multiple blood transfusion and there was failure to thrive. Received adequate course of iron. On investigating the child, we found hemoglobin to be 5.8 grams. And on peripheral smear, there was severe microcytosis, hypochromia, pencil and tear drop cells were seen. LFTs, RFTs were normal, serum ferritin was low, and stool for occult blood was positive. So diagnosis was iron deficiency anemia, definitely. The cause was due to the chronic blood loss. So we did colonoscopy and we found, as you can see in the picture, that there was a large rectal polyp. So we did the polypectomy and child responded well after 3 to 4 days. Symptoms resolved and child started gaining weight as well as the hemoglobin. So coming to my take-home message, that always have a checklist when treating a child with anemia. First check for the iron formulation, doses, compliance. Concomitant medicines. Always take the feeding history, especially for the cow milk, and take the history for any of the blood losses. Always rule out celiac disease, chronic infection and inflammatory disorders. Look for other causes of microcytic hypochronic anemia like thalassemia minor and lead poisoning. Thank you so much.
Thank you, Dr. Anubhuti, for a nice session. And now I would request Dr. Parmeshwari Mishra ma'am for her expert opinion regarding the topic.
Hello, good evening, everybody. Thank you very much, Anshita, and thank you very much, Anubhuti, for this crisp, elaborative, detailed AI causes of anemia. What I felt after this whole session, that all chronic diseases goes through gut health and affect gut and ultimately anemia. सारी chronic diseases में anemia हो जाता है और ultimately वो they affect gut, poor absorption, poor nutrition, poor intake, poor appetite due to chronic diseases, and ultimately anemia happens. What I now everybody did academically excellent. मैं अब थोड़ी सी कम्युनिटी की बात करूंगी क्योंकि हम लोग मैं पिछले 40 ईयर से कम्युनिटी में एनीमिया का बहुत देखा मैंने कॉजेज और थोड़ा सा मोस्ट ऑफ देम व्हाट आई फाउंड कि बिलो 5 years एनीमिया वाज टू मच. Then school going age, middle section school going age, anemia was less due to midday meals in the schools, and lower strata is getting proper nutrition and getting less anemia. Then adolescent girls had again anemia rises. So in our time, just now Harvinder joined, I saw her and उसको देखते ही मुझे anemia tremor syndrome याद आ गया, ATS, जो हम उदयपुर में every 5th or 7th child used to find anemia tremor syndrome, जो आजकल तो जो आजकल तो देखने को बहुत ही कम मिलता है, उस समय बहुत ज्यादा होता था. और उसका मेजर कॉज उस समय लोअर सोशल इकोनॉमिक स्टेटा होता था. अब इकोनॉमिक अपलिफ्ट हो गया सब में, तो एनीमिया का कॉज इकोनॉमी इज नो मोर नाउ. मोस्ट ऑफ द पीपल आर कैन एबल टू गिव प्रॉपर न्यूट्रिशन, but due to chronic diseases poor absorption happens most of the time. और ये prolonged milk intake is another cause. Then worm infestation बहुत ज्यादा है और पुअर हाइजीन. और जब हमने आंगनबाड़ीज में देखा कि आंगनबाड़ी once I visited in Jaipur periphery only, and I found all the 90 children were anemic, every one of them anemic. उसके बाद हम hemoglobinometry ले जाने लगे साथ में कि देखेंगे ये ऐसे ही दिखने में लगता है क्या, तो 60 to 90% kids were anemic. फिर हमने देखा कि यहाँ तो गवर्नमेंट तो बहुत आयरन दे रही है और सबको वो पैकेट्स बना बना के आयरन देते थे, तो हमने फिर सबका कहा कि तुम अपने घर से जो दवाई जितनी बची हुई है वो लेके आओ. तो देखा ये सबके घर में आयरन टैबलेट्स ऐसे मतलब भर भर के थे, 100 ग्राम to 1 kg. एक फैमिली थी जिसमें 16 विमेन थी, सब एनीमिक थी और उनके घर में ऑलमोस्ट 1 kg आयरन टैबलेट्स भी फाउंड. वो क्या करती थी, ले जाती थी एंड सब आयरन इज नॉट गुड इन टेस्ट, और वो अगर एम्प्टी स्टमक ले ली, वो वॉमिट हो गई, नोजिया हो गया, तो वो उसके बाद आयरन ले जाते थे, रख देते थे, खाते नहीं थे. तो ये एक बहुत ज्यादा था. फिर मिल्क इनटेक आप छुड़वा नहीं सकते उनसे. और पेरिफ्री में राजस्थान में तो गांव में बहुत है कि बच्चा खाता पीता नहीं है, कोई बात नहीं, दूध पिला दो, दूध पिला दो, दूध पिला दो. अप टू 5 years दे गिव मिल्क 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 मोस्ट ऑफ द टाइम. और फिर यहाँ पे मैंने देखा कि जयपुर की पेरिफ्री में वो मॉर्निंग में सिर्फ छाछ और रोटी दे देते थे, पुअर न्यूट्रिशन होता था, अगेन एनेमिक, और खाते नहीं है करके. फिर ये पुअर न्यूट्रिशन के बाद में क्रॉनिक डिजीजेस ने अपना वो कर लिया, फिर वॉर्म इन्फेस्टेशन ने अपना वो कर लिया. सो मोस्ट ऑफ देम इफेक्टेड जीआई अल्टीमेटली, है ना, गैस्ट्रिक, और वो पुअर इनटेक होने से एनीमिया होता है. तो all diseases we have controlled, and then anemia will definitely improve. मिल्क अब बहुत कम हो जाए, बॉटल फीडिंग इज अनदर वेरी मेजर कॉज. फिर हमने सबको वहां पे समझाया, बताया कि मिल्क नहीं देना, फिर गुड़ का, फिर चने का, ये सब हमने डाइटरी इनटेक उनको बताया. और फिर धीरे धीरे व्हाट वी सी नाउ कि एनीमिया इज रिड्यूसेस in due to nutrition. Anemia is less now, and due to worm infestation also, now schools provide deworming, they do regularly, so anemia is less. So let's hope for the best, and all sessions are excellent, and Anubhuti, you did really good. Thank you so much.
Thank you so much, ma'am.
Thank you so much, Dr. Anubhuti and Parmeshwari ma'am. So it was definitely very nice and enlightening session. And we think that anemia usually is very a simple clinical diagnosis, but to evaluate it completely and to know the etiology is very complex, considering all the etiologies of anemia, including your nutritional, your B12, iron, all metabolism, pathophysiology, everything into its place. So definitely it's very complex diagnosis. complex thing to treat, not to the diagnosis point of view. So now I'll request other dignitaries to who are associated with us in the session to have their comments in the session. And after that,
Asha ma'am for the inputs.
एक मॉडर्न कॉज भी आया एनीमिया का कि एक्सेसिव स्क्रीन टाइम फीडिंग.
Okay. Nice to see you, Parveshwari, and all of you. I was intermittently present because I had an institutional ethical committee meeting.
Thank you.
Congratulations, dear. You did a fantastic job, but you should go ahead and publish an IAP alternate journal called iCares. That is one thing. Next thing is, we are just doing hemoglobin peripheral smear and all that. We should do a iron profile. Total iron binding capacity, iron saturation, hepcidin, and ferritin. These are all going to help us tremendously. Now, people are looking at ferritin levels to diagnose anemia because the store is getting out from the hemoglobin. If you go backwards, and you must look at ferritin levels. Also, remember, high ferritin levels is a sign of inflammation. And you were telling me about this one. There are gut-friendly iron preparations. So think of that. And now the new concept is at 9 p.m. If you give iron preparation along with lemon juice, the absorption is very fast. And you can find improvement within 3 to 4 days. Because there is a receptor called hepcidin, which prevents iron absorption from the ileum. And I believe it is sleeping from 9 to 10. So let's capitalize on that and work. And dear girls, remember that becoming the member of the Women Pediatrician Forum has enormous benefits. So you are with all of us. So once again, congratulations and thank you for giving me this opportunity.
thank you so much, ma'am. I would like to thank all the dignitaries, guest of honor, chairperson, and all the speakers for this wonderful session. And now I would like to give over to Dr. Neetu Beniwal, ma'am, who is Associate Professor at Pediatrics at INT Medical College, for the question and answer session and taking it further. Over to Neetu, ma'am.
Thank you, Dr. Ansita. At the outset, I congratulate WPF Rajasthan for first ever academic activity by any state WPF branch ever. And in the last 1 hour, we have gone through anemia in children by the perspective of a nephrologist, endocrinologist, and gastroenterologist. So all the lectures were crisp and brainstorming. Now I invite the house for any questions. I asked for questions in chat box, but I didn't get any. So if any of the participants have any questions, they can ask.
I want to ask Dr. Anuradha, because Dr. Parmeshwari was telling that in Udaipur she was seeing the ITS cases, infantile tremor syndrome. Is she still encountering such cases?
Yes, ma'am. We are having multiple cases.
That's what I wanted to say. It's not just the cause has been told, because I found that in MP tribes or MP Rajasthan border tribes, it's very common. So it has some genetic background also with associated with this.
Actually, there is also a strong association with vitamin B12 deficiency in these cases.
And that is all well established.
Yes, definitely in tribal community, we are having multiple cases of the nutritional tremor syndrome. We are seeing them day in and day out.
They are in poor state actually. Poor that
In Jaipur, we are not seeing such cases much.
We are seeing many cases in JK Hospital. Many cases of
they are referred cases might be coming from
direct patients are coming.
Direct coming.
Yeah,
it's still there, but not that much that they are there on MP Rajasthan border. There are too many cases there, because when I was in Jhalawad, I've seen too many cases there.
That may be the reason. Maybe the other reasons may be there.
But I think, as she was telling, nutrition anemia is actually, it is now decreasing. It is there in poor, but it's not there. Because any chronic disease, there is a chronic, whether it is endocrinal or renal or anyone else, if there is a chronic inflammation and cytokine imbalance, which adds on anemia. So we have to always look for the underlying cause in all anemia cause. Besides nutritional,
Main thing
there are
is we
usually
should,
find some cause underlying there.
there is always some cause of anemia.
Yeah, yeah.
If you don't treat the cause, you are not going to correct the anemia.
Definitely, definitely.
So what your mind knows, your eyes will see, and what your ear knows, mind knows, ears will hear. वो वाली बात तो ही है. So it's important to find out the cause of the anemia. And if you treat that cause, whether it is nephro or gastro or endocrine or other causes, anything. So the treatment of cause is important here than rather treating only anemia.
Yeah, that's true.
Gut health we have to take care. Basically, if we'll take gut health care,
yes,
due to chronic disease, then absorption will definitely improve and anemia automatically
पेट
improves.
से सब डिजीज शुरू होती है, पेट से खत्म होती है. I agree with you.
जमाने में यही कहा जाता है, हमें यही कहते हैं कि सब कुछ पेट से ही शुरू होता है. And the most important thing is the diet, which is very, very poor. The most important thing, I feel, whatever, and we have to investigate, that is there. But telling about, other than giving the medicines, telling them about the diet part is most important for long term effect. Because अभी जैसा बताया कि किलो भर के अंदर रखी हुई हैं गोलियां, अब लिख भी दो, फर्क नहीं पड़ने वाला. थोड़ा सा डाइट, और वो भी जो whatever available indigenous is most important thing. That is the thing. Believe that.
Counseling is very important.
Yeah.
Dr. Asha Benakappa is the example. She was getting treatment for so long, but her dietary changes and all that made her so many difference.
Yeah. So
I'm also on the
So
same path. I know she's right.
yes.
Someone has asked, can we continue iron while the child is on antibiotic? Actually, Asa ma'am has answered in the chat box only that no iron when child on antibiotic.
Yeah.
Anyone-
No, it's not antibiotic. It is infection, or when there is inflammation is going on, there is oxidative stress. At that time, iron will increase the bacterial infection. It is not the antibiotic. It is the infection. With that, we should not treat. That's why we say till the treatment is going on with antibiotics, or the infection still has not subsided, we should not start iron. I think
someone has asked if does tremors completely subside in ITS while on vitamin B12 therapy? So actually we have seen much improvement in the tremors, and also the neurological development also improves after giving vitamin B12 and definitely dietary therapy in these babies. And if any of the speakers or chairpersons, they want to comment on this question, they are welcome.
We need all the factors of vitamin B12. We need to give folate also, and we need to give vitamin riboflavin. All these should be given along with not only the B12. Then the ITS improves. When we were doing
B12
PG,
we have to give, but along with that we have to change the diet. Which was only on breastfeeding, and mother was also deficient on B12. Mother has to be also be treated.
Just roti khila denge, that's it. We need to get the diet. We used to say a lot of cases.
I just wanted to make a comment here that in your OPD practice, I mean, everybody must be facing this, that parents want supplements. I mean, nobody wants to make a change in what they're making their child eat. And the crux of whole treatment therapy or anything otherwise also is that unless you're balancing your nutrition, you cannot have a good result. Because, I mean, the drugs are, that's what I tell my patients, ki dawai kab tak khaoge? Unless and until you're bringing a radical change in what you are making your child eat in routine, you cannot have a good hemoglobin or otherwise also.
What I do, I tell them कि when you come next time, I will not charge you fees if you write all 7 days meals in your house, what you give, so that we can make out. And then when they come next time, they definitely come because it's not going to pay also. And when you see that only 30% diet is healthy, most of them बच्चे तो French fries खा रहे हैं, बीमार हैं तो और कुछ नहीं खाते, है ना? तो खा रहे हैं, मैगी खाते हैं, फ्रेंच फ्राइज खाते हैं और इस तरह से. तो फिर देन यू टेक होल सेशन टू इम्प्रूव देम. और उनको बताओ कि चना खाओ, गुड़ खाओ. ये तो वो तो लगता है उनको चना गुड़ खाएंगे. तो
मेरा
एक
भी
बहुत
experience. I also want to share one experience that poor people they come. गरीब लोग बोलते हैं हम तो बहुत गरीब हैं मैडम. जब when you tell them about eating things, आपको डाइट बताओ, वो कहेंगे हम बहुत गरीब हैं मैडम, हम नहीं खरीद सकते. आप है ना कोई टॉनिक लिख दो. मैंने ऐसा किया भी है. मैंने उनको बोला इतने रुपए का ये टॉनिक है, ठीक है, और ये टॉनिक खरीदने की जगह तुम रोज आओ, मैं तुम्हारे को फ्रूट देती हूँ, रोज 2 केले खिलाओ अपने बच्चे को, ये टॉनिक नहीं खरीदना है. तो दे कैन बाय मेडिसिन, दे लाइक टू बाय मेडिसिन, पर खाते समय बोलेंगे हम बहुत गरीब हैं, कुछ नहीं खरीद सकते. ये बात है.
मैडम
So,
वो कीवी खिलाएंगे, सब इतना फैशन हो गया कीवी खिलाने का, कीवी खिलाएंगे पर केला नहीं खिलाएंगे, है ना. वायरल हुआ है कीवी खिलाएंगे पर केला नहीं खिलाएंगे, गुड़ नहीं खिलाएंगे.
खिलाना है उनको, प्लेटलेट बढ़ानी है. डेंगू में तो हर बेड पे आपको कीवी मिल जाएगी पूरे हॉस्पिटल में.
पानी पिलाएंगे और कीवी खिलाएंगे. अरे छाछ पिलाओ, केला खिलाओ, जो तुम्हारा डबल आ जाए, तुम्हारी इकोनॉमी इंप्रूव हो.
I don't know. This is a taboo. क्योंकि
Ma'am?
जैसे आप बोलोगे केला खिलाना है.
Yes.
हम
Ma'am,
केला
I think the time is over. 3 minutes over. We are going. So
Yeah.
first we will do vote of thanks, and then we will stop the YouTube recording, and then we can discuss if suppose you
Yes.
think go ahead with the normal discussion. Okay. So I request who is going to give vote of thanks today. I request our dignitary to give vote of thanks, and then we will stop the YouTube recording because this will go all over across the India, na?
Thank you, ma'am. Thank you. I first of all, I thank our guest of honor for today, Dr. Madhu Raturi, madam, for her affection and support for us always. And I'm grateful to our chairpersons, Dr. Kusum Devpura, ma'am, Dr. Madhu Mathur, ma'am, and Dr. Parmeshwari Mishra, ma'am, for sparing their time to chair this session and giving their valuable feedbacks. And I'm also thankful to all the speakers for such elaborative and interesting lectures and sparing out their time. And I'm very much thankful to our WPF chair, dear Dr. Sangita Lodha ma'am, our Secretary General Dr. Anuradha ma'am, Vice President Dr. Elizabeth ma'am, for their untiring effort and always bringing up new ideas for WPF academics and webinars. And last but not the least, I am thankful to all the dear participants for their patient listening and making this webinar successful. Thank you very much.
And thanks to
Thank you
Pallavi
to
also, who is our
Anshita
tech head
also
and
for moderating
support
the
it very
session
well.
so well. Thanks to
up
Anshita
next-
for moderating the session so well.
Yes, thanks
Thank
to
you, thank
Anshita
you.
also.
Thank you.
She's a very dear friend and a very nice girl.
Thank you. Thank you, ma'am.
Thank you so much.
Thank you, everyone. Our next activity on WPF platform will be a tete-a-tete session by Dr. Asha Benkappa, ma'am. That will be on the 28th of August. The topic will be trial regulations and triumphs. She is excellent orator and we would like to learn and listen her. And in that session, we will introduce our youth editors who will be editing our second edition of our magazine, We Connect, and which we are going to launch very soon. And as we are heading towards the Independence Day in 2 days, it is a time for the national anthem displayed by Dr. Anshita.
Great.
I cannot share the screen, so I think Pallavi has to.
Even the audio is enough.
Yes.
Anshita ma'am, in that PPT on the that audio is there or what?
Sorry, ma'am. Shall I
Did
play?
you send me that audio or that?
No, I'm playing it through laptop.
Okay, no
Just-
problem. Thank you.
And who is singing or playing?
Just singers.
Anshita ma'am, no audio is there.
Ma'am, we
can
all
sing together and
We can sing it on our own.
Anshita, can you sing right now?
Okay, it was not audible, ma'am.
Want to play with the music?
No ma'am. No ma'am.
I think its
Oh.
volume is not.
Okay. So if you all can sing, ma'am, that would be
Yes.
great.
Yes.
Or anybody can take the lead.
जन मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड़ विंध्य हिमाचल यमुना गंगा उत्कल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे तब जय गाता जय गण मंगल दायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
भारत माता की
जय
nice session.
And happy Independence Day in advance to all of you. This
Happy
will be
Independence Day.
Independence Day. And let's keep
सारी
your
शुभकामनाएं
for a group photo.
स्वतंत्रता दिवस की। सबसे अच्छी बात हमारी अमन चैन हो और जो मेडिकल फ्रेटर्निटी के अगेंस्ट ये सब कुछ चल रहा है, कोशिश और उम्मीद सोच यही है सुधरे। ये हालात हैं, उन सब के कारण काफी मन दुखी होता है। सब लोग इतनी मेहनत करके और डॉक्टर्स बनते हैं, सबसे डिफिकल्ट प्रोफेशन, इतनी ड्यूटीज करते हैं, उसके लिए कुछ ना कुछ हम सब लोगों को करना चाहिए। उन लोग क्या कर सकते हैं अपनी अपनी जगह, लेकिन खाली स्ट्राइक, कैंडल मार्च मुझे नहीं लगता कुछ विशेष कर पाता है। व्हाट इज टू बी डन, ये कुछ सीरियस थॉट सबको लेना चाहिए, क्योंकि इस तरह जो थ्रेट सोसाइटी का मॉरल तो बिल्कुल डाउन हो चुका है। सो आई डोंट नो क्या सबको करना चाहिए मिलकर। सब लोग अपने अपने सजेशंस भी लिखें, कुछ अगर सब कर सकते हैं प्रोटेस्ट, तो सिर्फ वर्बल रह जाता है।
It's time for a group photograph. आप सबकी कलरफुल छवि डिस्प्ले करने का टाइम है. Please spread it. Let's have a group photograph. Keep your cameras on. Pallavi ji, are you clicking?
Yes ma'am. I'm taking the group photo.
Bad. Thank you so much, each one of you.
Thank you so much.
Thank you so much.
Thank you, Anuradha.
Sangita ma'am, which state will be coming next month?
Either Orissa or South. We will take
We'll let you.
Telangana or Orissa, any one of the state. I will just ask them. Probably Lina Das madam is ready to just do it for the next month.